requirements, looked at network adequacy, participant protection, marketing and outreach, quality standards, rates and contracts, and NCO qualification. So it's been a very robust dialogue. And that will continue today with our, our agenda, which we plan to cover geographic scope again, consolidation of existing programs and opportunities there within, and Medicare integration in the transition process. So, to date we have received a lot of valuable feedback from statements and questions that have come up, both during in-person meetings as well as afterwards in the follow-up and comment period by all the attendees, and we are going through a really, robust process to strategically examine all the questions and all the issues that have been brought to our attention in deciding, what the next steps will be. So we're, just so folks know, after this meeting, we're intending to allow for an additional comment period, and that will include all topics covered for all the sessions. Feel free to reach out to us, not just on topics covered this session, but we're happy to take questions about topics covered in other sessions. And I think that will really give folks another opportunity to provide written feedback in case, I know we have trouble right now with the webinar. This is being recorded, so I'm told. So hopefully folks will have an opportunity to either listen to the session if they couldn't join today or provide additional feedback. We are setting the due date for all additional comments as of January 12th, 2018. I think that's we're all driving to, but I know it's a busy time of year, and I know there are a couple other competing priorities going on right now, so I don't want folks to feel overwhelmed by that date. We can always re-examine that date if that becomes necessary, but it might be best just to send in your comments quickly in terms of reactions, because I think folks typically, have, when it's freshest in their mind, probably have all the questions, so that would be helpful. So again, thank you all for attending. We'd like to welcome all of our managed care plans, all the participating providers and advocates, and all the rest of the stakeholders, trades. I'd also like to thank folks at CMS who are always joining us for these meetings. They've been terrific and really shepherding this process along, and really their involvement has been so beneficial in partnering, to look at the future here of integrated care. So thank you to Melissa Steele and Toby Oliver and Alex Kraus from the Integrated Care Resource Center, or if I said that wrong, Alex Cruz. I'm sorry, Alex. Okay. Yes, who will be speaking today, I believe, right? And so we're very excited to have Alex here. And then our team from DOH, Erin K. Flickia, Kurt Dobson, Alyssa Halperin, Madeline Royale, Patrick Cuccinelli, who's outside taking names, and Francis Ness, who organizes the webinars, and then Renee LeBrit, who was not able to be here today. So thank you, everyone. I'm going to turn it over now to Erin K. Flickia, who is going to review kind of the agenda for the day, and then lead us through the next topic.
Welcome, everybody, and thank you, Andrew. Also wanted to thank Andrew for giving us all the support that he's given us through this process and allowing us to assemble this great team and helping us get this whole series together. And also to Joe Shunk, who's been absolutely critical together. So we'll dive right into the overview of the process. I see a lot of faces in this room who have been here at every single meeting, so those of you who have been here, you can just tune out for the next 2 minutes. Kind of a ritual for that. But we will start with the meeting materials. You should all see that prior to this meeting, we sent out a packet of information, which has drafts of discussion language, which sometimes can look like a contract. We want to just make sure that they're never really proposed contracts. These are just discussion language, something for you to react to and give us your thoughts on. So that packet went out to everybody, I think, did it go out yesterday, maybe day before. In the last few days, that packet went out, so everybody should have that packet that you can be looking at while we're going through this. And it is on the 4 topics that we have reserved for discussion at this meeting. It's not meant to be all-encompassing, this language that we put together for any specific program. We created it really as a means of gathering information input from all stakeholders, whether you're providers or payers or advocates. And we are going to cover the 4 topics today that are set forth in the package materials, one of which is geographic scope, which we covered, I believe, in the first of our topic series. And we thought it was important enough that now we've gone through the whole series and gained some feedback that we kind of touch on it again and see if perceptions have changed as we've gone through this series. All comments are welcome today, as always, but we do ask that you try to limit your comments to the topic we're covering at the time, because while we want to hear everything, we want to also make sure that we're able to accurately gather comments when we put out materials for what was discussed and what was said, and also it helps us, if we do run into any time issues, it helps us to stay on track and make sure we're covering everything that we want to, especially since this is the last session in the series. We will be taking comments from the webinar as well as from the room. We do have webinar, Francis, can they hear us? I'm not sure, but we are recording. Okay, just in case webinar folks are there, we'll take your questions. If not, it could go pretty quickly today. We do ask that you come forward, yes, to the microphone. Do we have a microphone today for comments? Are we? Oh, look at that. We have a podium for it today. So that's great. So it does help in case we do have the webinar people, and also because we are preparing transcripts of these. If you do step to the microphone, please, to say your questions, then we can capture everything to the transcript. It gives us all for historic value for what was said, and for us in CMS to go back and capture everything. Very helpful. We do ask for follow-up comments in case you don't want to come to the microphone today, or if you think of your comment or question after the meeting. We do have a VML that we would like for you to use, which is in the slide deck, and it is Future of Integrated Care at health.ny.gov. That helps us to track all the comments and to make sure that we, in a coordinated way, get responses back. We do take all of those comments that come in, both here and through the VML, and we put them all together in a template, and then we can go over them with CMS. We can form any decisions that we are eventually going to make based on them, and we will also post them all once the transcripts and everything comes in and it's all ready. It will all be posted on our website. Let's see, what else do we have for housekeeping? I guess I just covered it all. The last point was that we are going to CMS, as always. After every one of these series, we meet with CMS and we review all the comments. This one being the last one, we are going to give a little more time. Please let us know if that January 12th date works for everyone. We don't want to rush it, but we won't want to leave it forever also. So we're going to give a quick review of sessions 1, 2, 3, and 4, this being session 5. So our first session was in July, was the kickoff for the stakeholder process. As cold as it is today, I think we were in this room, right? Were we right here? And it was so hot that day, I remember. I'm missing that a little bit right now. The DOH team presented on the value and importance of planning for the future of integrated care in New York State following the end of 2019, when the FIDA demonstration is slated to end. Lindsay Barnett from the Medicare Medicaid Coordination Office at CMS was there that day, and she also offered a status update on the Medicare and Medicaid Financial Alignment Initiative. Those slide decks, all of these, if you want to refresh, are all available through our website. And that day, James Verdier from Mathematics Policy Research and Anne Mary Phillips from the Center, at the time, from the Center for Healthcare Strategies, had presented on other state approaches to integrating Medicare and Medicaid for dually eligible beneficiaries and the implications for the New York State FIDA demonstration. Those materials are available there. Following that July meeting, we sent out a survey to the stakeholder group requesting information on formatting for the follow-up stakeholder process. Based on that survey and on the feedback that we received during the preliminary meeting, we scheduled 4 subsequent sessions. And we alternated, based on the survey results, we alternated between Albany and New York. So session 2 was in Albany, and it was on September 7th. Those topics we covered that day were the target population, covered services, care coordination and care management, covered the topics of network adequacy and access, participant rights and protections, marketing rules and flexibility, and quality standards and measures. Last month, we went back to Albany and we held session 4 on November 16th. We had that day our colleagues from the Department of Health Division of Finance and Rate Setting, and so Jack Patera and Renetta Robinson came that day, and Jessica May from CMS, and they sat on the panel to address payment and rate considerations, outreach, education, and engagement of participants and providers, MCO plan requirements and qualifications, and enrollment. So we can dive right into our topics today, starting with the revisit to geographic scope, and I will turn it over to Madeline Royal and Patrick Cuccinelli from the Department of Health.
Okay, thanks, Patrick. Thank you, Hannah, and thanks for that introduction. Hello, everyone. For purposes of this discussion, Patrick and I will be laying out a visual of the products that currently exist throughout New York State. The package that, can everyone hear me okay? Is everyone alive? The package that, is that better? Okay. The packet that Erin Kate referenced may look a little bit different than what you've typically seen for contract language. It is actually an outline of the Medicare Advantage and the SNP products, which will align with the maps that are coming to follow. Patrick, as we go through the maps, will give a high-level review of what the content is in the packets here.
If I could just, one thing, let me know if you can't hear me, but it did not escape our notice, Madeline and I, that we have geographic scope and landscape. We did try to come up with details on that, so.
The most I have is that the next slide that you'll see is very colorful and warm, and that's about as close as we will get to warmth in New York State here. So the map that you see before you is of New York State Department of Health Managed Long-Term Care plans by county. So if you'll take a look throughout the state, we have partials throughout that's outlined in the purple here. If you go over to the 5 boroughs, you see we have partial, PACE, MAP, FIDA, and FIDA IDD. Then over to the western region, the county, yes, sporadically throughout, those are highlighted in blue, the PACE and partials. It's a little piece in orange, your partial, PACE, and MAP. So we just really wanted to highlight where some of the dual products are throughout New York State. This map does not contain the Medicare Advantage or the SNP. We're actually going to go into those in the next slide. So now this map here, this is the Medicare Advantage enrollment percentage and number of contracts per county, which we found this map to be very interesting. As you'll see throughout the state, highlighted in the orange, we have a consistent about 20 to 49% enrolled in the Medicare Advantage lines of business. And then here on the western side, you have this little pocket here of over 50% of enrollment, thanks Patrick. And then in the Bronx, there's the same of the 50% over here. Also highlighted up there in the, so Patrick will take us through a high level, in the bottom tier there is where it's under 20% enrolled in the Medicare Advantage. So Patrick will take us through a high level.
When we get to the questions, I think it might be interesting to talk about what is happening in a very neat little square of counties out there in Western New York. Anyone here from Western New York? Usually you don't get Western New York downstate, you don't get downstate from Western New York. There is a very prominent Medicare HMO of preferred care out there, and they're very aggressive or successful in marketing. So anyway, you have with your handout out data on Medicare Advantage and D-SNP, and it's divided into sections in terms of Medicare Advantage program. And our thinking on this was that those areas of the state or those programs that have been successful in terms of reaching out with an integrated Medicare product are also the ones that we might be most successful at in terms of integrating Medicare and Medicaid. And actually, that came out as a consistent theme at the last session where we were talking about finance. So if you just go into that packet, we have across all the highest penetration of Medicare Advantage in California with 9%. But if you look at that little area of western New York, that actually gets pretty close to that high in California. Among our neighboring states, we have 31% in Pennsylvania, 25% New Jersey, 34% in Massachusetts. Then you see in the next chart, there is 70%, the vast majority of our Medicare Advantage. Now, the information that's on this map is and you see New York State comes in overall at 38.8% Medicare Advantage enrollment among eligible providers. And then there's just variations on how that data is presented. With Table 4 having the largest number of contracts and the lowest number of contracts in Livingston County, which is somewhere around here, and with only 8 contracts. Any questions so far? I'm sorry. Oh. No, we didn't. That's the question is, when we look at income distribution in relation with where we have the high rates of HMO penetration, that's an excellent point. That's something to take a look at.
And that is part of what we wanted to discuss before we move on from this map is, any feedback that you may have or thoughts that you may have that contribute to this variance in the Medicare Advantage distribution throughout New York State. So we'll open the floor if anybody has any other ideas.
And you've got a couple of maps in that package. Then you've got a section.
That was sort of my reaction.
Can you come up to the microphone? Thank you.
Because, when I talk to our the people that are just a little bit over that maybe a little problem, they are looking at Medicare as
Who are your consumers?
I'm at 100% before, so it's so yeah, so it's but that was my reaction about the Bronx, but then I didn't know what York. But Buffalo is pretty low.
Thank you. Just for purposes of the WebEx and just to make sure that everyone is here, we just ask that you come up to the microphone and also introduce yourself when you come to provide commentary or ask any questions, just so everyone can hear.
So then you've got a section on and the first chart you come to is the managed care enrollment integrated provider on the D-SNP, and you see that the vast majority of people are in a dual eligible SNP. You also have the vast majority of Medicare Advantage are in non-special needs plans. And we have a chart that shows the county, the plans between the bronze. You want to talk about this now? map gives the number of contracts in various areas of the state
Specifically for the SNP.
for the special needs one, yes. Then you've got a couple more charts. Table 5 is your Medicare special needs number, and you'll see health workers down at 73,000 or 27% of the total D-SNP enrollment in the state. And at the bottom of the list, you have Centers Plan for Healthy Living, which is in the New York City metro area, Western New York. And that data is just presented in a couple of different formats in terms of whether it's a dual eligible or an institutional SNP. And then the last chart that we present has to do with the non-FIDA county enrollment, and that arranged by percent enrolled. 19% are 9,000 in Erie County, and that drops down to the low of essentially 0% in Tompkins County. So we have 4 or 5 counties in the state that have no SNP enrollment. Any questions?
So we did poll some questions, and feel free to either voice your responses here or take them back and respond through the VML for those that are on the WebEx. Looking at our geographic scope here throughout New York State, one of the questions we have is which geographic areas should be included as we move forward with the future of integrated care? Opinion. Okay.
Well, we've had prior conversations in these meetings where people felt like something like a statewide FIDA type of program might be what we would be looking at. I don't know if people still have any strong feelings about that.
I would recommend a statewide approach. I think that's what we said at the last meeting. I guess the thing I'm reacting to, the gentleman said a statewide FIDA, and I don't know that I would replicate FIDA model. I think a statewide approach would be good, but on the map, there is a large number of Medicare Advantage plans already available in every county in the state, and maybe that's the way, maybe that's the foundation.
Well, that's why we felt it was important to present the Medicare Advantage information.
Yeah.
So, yeah, that's a great point.
Thank you. Next question is if all areas should be included. I'm sorry. Other question.
This came up when the network discussed about network management.
Could you just state your name and where you're from?
Lauren Island. In terms of the solution, I think the reality that you also have to take into account about different kinds of attitudes. Because when you look at Medicare and service concepts, you are going to have different providers, different networks may not want to work. And so even in two, which is Westminster and Suffolk, FIDA, you have where it's taking time to get the network in that process. So if there is a desire and a will to have a statewide solution, I think it's very important that consideration about speaking it, because so much development has already been done downstate that tie those together will probably be somewhat delayed in executing a solution for downstate. And I think that the other aspect that the provider has not
that's a really great point, and it did come up as we discussed provider education and the route that we should take with that. And like Erin Kate mentioned prior, we will be going back to review all of the feedback and commentary that we had, discussing further movement with CMS and just how to pull this together. It actually leads us into our next question, which is if all areas should be included, should all begin at the same time, and if not, what timeline? And I think your point is we should stagger.
I think that there's an advantage with staggering. The other part is that with providers,
Right.
and that there's support in part, or if it is that
I think you make a very good point, and I would really encourage you to actually, if you wouldn't mind sending that to the DML as well, your comment. We were taking it down and recording, but that was good. Thank you.
on behavioral mental health and home care options. My take on it is that allow model startup state close down of it. Being an upstate only plan, we're quite many MLC in play as we roll out. We have, while there is a problem in Africana Peaceful County, there simply aren't the providers, but there are those that are already operating out there in place. So, I know you think one can call that opportunity instead of out there.
Understood. Thank you. Any other questions or responses to this question? And lastly, we have what preparatory steps are necessary to build for 2020 in all geographic areas? I mean, I think from what has been stated already, we do hear that there should be a lot of provider education and to make sure that it is even throughout the state to give everybody a fair playing ground.
Moving on, mentioning why time content well.
Make great points. I just one question for you. What would you suggest, or how do you think it would be the best route to begin to engage the providers more?
Far from that response. There.
Thank you.
You mentioned the term leverage in those areas where you already have Medicare Advantage. Shake your head no, so.
I would strongly encourage you to discuss that. And the best way that it was described as that is because at the most providers work with it is a very different model, and they are there in a facility. While there may be some, they're private, it's a different model for, and in terms of what you're describing, which is a potential statewide solution, I can't see that you will have that type of involvement. And that's not. Eligible. I don't know what that work process is like for you in terms of developing free, getting that deployment so that people make the they'd like to participate. But those will be very
Thank you for that feedback. We will absolutely bring us all back together, meeting together internally with various departments and the CMS to put together a lot of the commentary and feedback. Are there any other questions on the geographic scope before we turn over the webinar?
Frederick Marty, Director of Client Services at Medicare Right Center. And just looking at the previous map around Medicare Advantage, market penetration enrollment, I think it would be important to look at network advocacy, Kaiser Family Foundation, support research, connecting number of plans available, the level of enrollment in network advocacy that Kaiser has yet for other parts.
Okay, thank you.
Yeah, we'll definitely take a look at that.
Oh, I'm sorry. Your name again? Frederick Hardy was saying that we should take a look at Kaiser Permanente and some of the, actually just pulling it back to some of the networks and the provider enrollment.
Kaiser Family Foundation.
The Kaiser Family Foundation. Sure. Okay. So he was just saying that that is a crucial piece that we should take a look into as far as correlating the network and network accuracy for throughout the state. Any other comments or questions? Okay, then we
Well,
move on to the next.
in the spirit of the season, though, we are looking at I guess, the ghost of integrated care future, and hopefully it'll be a friendly spirit, and we'll give life integrated care each future.
Great. Up next is Alyssa.
Actually, I'm going to turn it over pretty quickly to Alex Cruz, but as she speaks and talks to us about what's happening in other states and around the country with integrated care and platforms for integration, I just ask that you think of some of these questions because we're going to come back to them once you've done. So, should the state request permission to continue using the existing MMP demonstration authorities, FIDA platforms? Should we ask CMS if there's a way that we can continue using them? Should we ask CMS for authority to do a completely new and different demonstration? Should we ask CMS for demonstration authority to carry forward some of the flexibilities of FIDA into a new and different platform that doesn't require wholesale demonstration authority to implement? Should we, as the state, use DSNP or a FIDE-SNP plus Medicaid plan as a model for integration moving forward? And what are the considerations that go into any of those decisions? So just please keep those in mind, and then I'll come back and see what feedback folks may have. And now I'd like to introduce Alex Cruz from CHCS and the Integrated Care Resource Center. And you will not be disappointed. Really glad to be here today, and want to point out that I threw my coffee cup away because I can't attend to it while I'm up here. So I want to make sure it doesn't spill. And I didn't know the rule before I came in. But it's nice to be with all of you today and talk to you a little bit about one mechanism that states around the country are using to advance integration that I know exists in New York State, but varies state to state, how much the DSNP platform is leveraged. But I'll be talking about that in the next probably 20 minutes or so, and looking forward to answering questions that folks might have. Most of the information I'll present is somewhat high level when it comes to how DSNP works. There's probably folks in the room who obviously operate these products who know a lot about the way that DSNP exists and operates in our state in relation to other programs, and so we'll be welcoming, having some conversation that you might want to add. And I also want to point out that there's a lot of different options, right, that states can pursue in terms of advancing Medicare and Medicaid alignment. And I won't be talking about, one of those, which I know is relevant in New York State and across the country, which is PACE, the PACE model. I may be referencing in the presentation how DSNP relate or compare the regular Medicare Advantage plans or to the FIDA program, but just want to, point out that we understand the value and the import of the PACE program. So moving on, just to show you the agenda of what I'll cover real quick, and this is the Integrated Care Resource Center. I should say you may be familiar since my colleague Jim Brasier and former colleague Mary Phillips presented at the meeting in July, worked with states around the country and the Medicare Medicaid Coordination Office on technical assistance and support to states, produces materials like some of those that have been shared with you in the materials for the meeting today, and this is just information on our web resources and contacts. So the agenda, I'm just going to go back one slide and just indicate that, I'll cover a little bit about the history and the purpose of DSNP, what that landscape looks like nationally, and the opportunities for states to use this model for Medicare and Medicaid alignment, and then talk just a little bit about comparisons between the DSNP model and other Medicare Advantage options, and as well as like the contracting basics. What is the requirement for DSNP that
And then last but not least, we'll share some information with you about a model in New Jersey that is actually the furthest you can, I would say, go on the DSNP platform in terms of alignment. So wanted to just share that as a comparison that might be helpful as you continue these discussions with New York State. So moving on to the first actual content slide. I think the next one. Yes, that's perfect. So the history and purpose of DSNP. The DSNP acronym that I've used obviously stands for Dual Eligible Special Needs Plan. And these are plans that were authorized back in 2003, began operating under the Medicare Advantage program in 2006. So we've got a little over 10 years of history of these plans being in the marketplace. And they are a type of Medicare Advantage prescription drug plan, or a type of Medicare Advantage plan. They're similar to Medicare Advantage prescription drug plans in that they have to meet all the same requirements. They have to provide all of the Medicare Part A, Part C, and D benefits. And the uniqueness of this particular plan type is that they are only permitted to enroll dual eligible. And they have to have certain requirements that are met that I will go through in a little bit more detail later, but one of them includes having a very distinct model of care management model that is tailored to meeting the needs and unique needs that Andrew was pointing out earlier that exist for the dual eligible population. There's been really steady enrollment growth, and we'll show you a slide of what that looks like in this model, and there's now over 2 million dual eligible enrollees in these products in 41 states. And in New York State, what that looks like is data that we just saw, but 230,000 individuals approximately in DSNP statewide, depending upon when you take that snapshot. And there's about 200,000 downstate and just 30,000 upstate. So the last thing just to share here for folks that may not be familiar, special needs plans, there's actually 3 types under the Medicare Advantage program. There's CSNPs, which are chronic condition special needs plans. There are institutional SNPs or I-SNPs. And of those types of Medicare products, nationally about half of the individuals in them are dually eligible, but there's not the same requirements. They can serve non-dually eligible Medicare beneficiaries. So moving on to the next slide, this one is a map that shows where DSNP enrollment is concentrated nationally, and it actually distinguishes between, the colors changed a little bit on us, I think, but in between the highest DSNP enrollment in some of these brown states, there's about 12 states that are shaded in brown, and the rest are yellow. Those are states that actually generally have a higher level of integration in their DSNP programs, some linkages between their DSNP and state Medicaid programs, so there's actually higher enrollment in those states. And then it may also correlate to just higher enrollment in Medicare Advantage products in general in those states as well. And Florida is an example of a state like that. And California as well. And then there's just, a point here that's, I think, helpful to be made early on in why we're even talking about, dual eligible special needs plans and bringing that into this conversation, which is that outside of the Financial Alignment Initiative or the FIDA program, as an example in New York, this really is, if you're thinking about how do you serve the most, the maximum number of dual eligibles in an integrated system of care, where could you effectively try to move, those individuals to? If you're a state that did not, move into the MMP model or the Financial Alignment Initiative, or if you're a state that's looking at, what comes next and what options exist, like New York is, DSNPs offer the greatest potential to serve the largest number of dual eligible. So I think that's probably it on this slide, and we'll move into the next one. So this is just a quick picture of growth. I think it represents a couple things about dual eligible special needs plans. One, that it's a relatively stable, platform under the Medicare Advantage program. It's been around 10 years. During that time, the enrollment and the actual, obviously, number of SNPs operating has been pretty steady. There was a change in about 2012, 2013, when there were some requirements added for saw kind of a change in the number of DSNPs that were operating nationally, but there's a lot of potential here. The current dual eligible special needs plan product under the Medicare program is authorized to continue through 2018, and it actually has time after time been reauthorized, and it's the understanding at this point, although there's legislative activity that has to happen at the federal level, is that this product would continue to be reauthorized. So the next slide covers the level of integration of Medicare Advantage plans that we're talking about today. This is in all of the Medicare Advantage plan types, but the ones that are leveraged for integration, being DSNPs and MMPs, as well as a comparison of the DSNP and the MMP model to a regular Medicare Advantage plan. And I just wanted to share at a high level that, when you're looking at a standard Medicare Advantage fee, there is actually, no specific requirement to coordinate across the Medicare and the Medicaid program. So individuals that may be, if there's a high penetration of Medicare Advantage and Relief, they may be in these products, and they may also be in a Medicaid product. There's not the same level of requirements that you see in DSNP and MMP models. The other thing that's interesting to point out here is just, thinking about relevance to New York State is that there's a pretty thoughtful design in the MAP program, and I think there's a variety of plans under MAP that may or may not have operate different types of Medicare Advantage products, DSNP or Medicare Advantage plans. And if someone was in a standard MAP plan with the Medicare Advantage product, you don't have the same requirements. And I'm not going into the difference between the DSNPs and the MMPs on this slide because I have a slide, it's just a little bit that will compare in more detail those models. So we can shift to the next slide, if that sounds good. So we're going to talk a little bit about comparison to other platforms and opportunities to contract with DSNP from the state perspective. So if we move on to the next slide. So this is just, integration basics, some of what we talked about, again, some that may not be new to many of you. But Medicare Advantage DSNPs provide all Medicare benefits. They have a responsibility to coordinate or arrange for Medicaid benefits. They may or may not actually be capitated to provide those. They have a separate contract between the state and CMS, and a number of states, an increasing number of states, are actually linking the companion Medicaid plan to a DSNP offering. And you'll see that, in real sense when I talk about New Jersey's model in a little bit. But the linkage between managed long-term services support and a dual eligible special needs plan for a number of states has provided, the greatest potential for integration of benefits and coordination of care. There is a subset of dual eligible special needs plans, which are referred to as FIDE SNPs, and there are, of course, FIDE SNPs operating in New York State, and they are fully integrated dual eligible special needs plans. They are plans that have requested a special designation from CMS because they achieve a higher level of alignment in both benefit integration, but also in some areas that might matter, let's say, to a beneficiary, which is perhaps an integrated grievance and appeals process at the plan level, or integrated materials. There has to be some level for a FIDE SNP of alignment administratively between the two programs, in addition to integration benefits. And then they, by virtue of being designated as a FIDE SNP, there's an opportunity for that plan to see if they would qualify for a relatively small but not insignificant Medicare payment, which is referred to as a frailty adjustment, to reflect the needs of individuals that are enrolled in the FIDE SNP. And it is the most integrated DSNP option. So moving on to the next slide, I alluded to this earlier, but in January of 2013, there was a new requirement that was implemented, and this was for dual eligible special needs plans. that they have to operate, the DSNP has to have a contract with the state in which it wants to operate. So these are referred to, I think, in New York State as coordination of benefits agreements. Nationally, sometimes they're referred to as DSNP contracts or MIPA agreements. But MIPA was the legislation that basically said, if you want to operate a DSNP, sit down, talk to the state that you're going to be operating in, establish a contract, show us that contract, and then we'll give you, a stamp to continue operating as this plan type. And the basic requirements for DSNP, I think, are interesting to point out that even now, as DSNPs have worked with their state partners to establish, these coordination of benefits agreements or MIPA contracts, there's pretty basic requirements that are the bar, right, that you have to meet. There are things like defining in the contract what service area is covered, which populations are going to be enrolled, what is the level of benefits that might be included under the DSNP, things like a few other requirements, of course, but, are you going to verify eligibility for Medicaid before you enroll in the DSNP? So these are not, the kinds of things you probably think about when you think about the FIDA program and some of the MMC requirements, which are really, built around how do you actually better coordinate and align these two programs and serve beneficiary. These are just kind of making sure at a minimum level that there's a conversation between states, and then it's really up to states to then decide, how do you use these coordination of benefit agreements to leverage, the DSNP model, and the level of integration that's achieved through these varies considerably across states. So, is there anything else I think I wanted to cover here? I think, just that there's a trend naturally for states to go beyond, those minimum MIPA requirements. There are opportunities to achieve, administrative, clinical, financial integration through these DSNP contracts that a lot of states have taken. So if we move to talk a little bit about the comparison of the dual eligible special needs plan model and the Medicare Medicaid plan, you'll get a sense looking at this that there's a lot of words, really tiny, small words on the slide. But there is, I think, just a couple, high-level things to point out. One is that through these two plan types, there is similarity in the first two categories. So you have an opportunity through both of these to have involvement between the states and the plans, and through the MMP model, you've got a three-way contract that brings CMS into the picture. The DSNPs have the contract approach that I just talked about. If you look at covered benefits, there's really an opportunity under both of these platforms to fully integrate care, that you can decide, at what level would someone who is enrolled in a DSNP or an MMP, what benefits would go into that on the Medicaid side. So there's similarity there. Where you get into, I think, some more significant differences between these models is, I'm going to start with the bottom first, but is, the opportunity for Medicare and Medicaid alignment. The FIDA model has, right, extensive, joint federal oversight, integrated financing and payments to the plans, actually uses an integrated enrollment mechanism so that someone who's negotiating the Medicaid and the Medicare program can go into the MMP product in one enrollment process instead of two distinct ones. And it actually has, marketing templates and review of is one example, but joint marketing templates, review of materials between the state and the federal partners, and just a lot more administrative alignment that can be achieved in the MMP platform. But it doesn't mean, right, that you can't achieve a good degree of Medicare and Medicaid alignment via DSNP. There's opportunities, I think, that are driven in part by the states and the health plans working together to figure out, what that alignment would look like. And then the other, thing I think to point out is just because it is separate contracts between the state and DSNP and CMS and the DSNP, is that, the level of financial, integration is different, but from a plan perspective, our experience working with states and talking to, plans that operate in both products is you can achieve, right, a similar level of financial integration at plan level because they may be getting two separate payments under a DSNP. The payment may be more integrated under an MMP model, but there's a plan level financial incentive under both models to be responsible for Medicare and Medicaid service delivery, and hopefully working with the providers within those networks, working within the care coordination models that are established, figure out how to maximize the delivery of those benefits to the best service of beneficiaries, but also to hopefully provide services in, the right setting. Provide home and community-based services in lieu of, hospitalization or nursing replacement, all those things that can be pretty important to the beneficiary. The last thing, I guess, to point out here is that there's differences in, of course, things like, quality rating system applicability under the Medicare D-SNP model. The STARS rating that applies to Medicare Advantage plans applies to those products. And so it's one set of quality metrics and incentives that are built into the Medicare Advantage STARS program. Under the MMPs, there is very specific quality withholds and different quality incentives that are built in. So that is probably more than folks ever care to know about the differences between the MMP and the D-SNP model, but I just want to be able to support your conversation to go forward. The last slide that I'm going to cover really just talks about a model in New Jersey that may be of interest, which is leveraging this platform to deliver full integration. And the person who oversees the D-SNP program in New Jersey likes to refer to this as essentially a fully integrated option for full benefit dual eligibles in New Jersey. If someone is a full benefit dual eligible and they're negotiating either a Medicaid system or the Medicare enrollment system, this is just a choice, right? If they want to obtain fully integrated care, and it's basically built on the alignment that I was talking about earlier between Medicaid offerings and the D-SNP. So what New Jersey does to create that option for duals is they actually offer an MLTSS plan under their Medicaid program. They established and launched Managed Long-Term Services Support in 2014. And they limit their D-SNP enrollment in New Jersey to a couple things. One, full benefit dual eligibles, but they also limit the enrollment to individuals who want to be in an integrated product. So D-SNPs in New Jersey are required to operate a Medicaid managed care plan, and then they're also required to operate a D-SNP, and in order to obtain the Medicaid contract, the state actually, I'm sorry for getting turned around, but in order to operate the Medicaid contract, the state actually requires that the health plans that are contracted in New Jersey make sure that they have approval to operate a D-SNP, and their service areas for their D-SNP and their Medicaid plan have to be aligned. So they kind of go through an approval process to operate the Medicaid plan, whatever the footprint that looks like for that plan. They have the same geographic footprint for their D-SNP, and that way there is a fully integrated option for people in those counties. There's a few other things to point out here, and of course, I'm happy to take questions, but New Jersey actually asked all the SNPs to request designation from CMS as a FIDE SNP so that there's an opportunity to obtain that frailty factor payment. And then they also have pretty robust care coordination administrative alignment requirements. They assign individuals on the Medicaid side who select the D-SNP for Medicare to the New Jersey Medicaid plan that matches that D-SNP, so they basically built some alignment into their state assignment process for Medicaid, what is in New Jersey mandatory Medicaid managed care. And then they do a lot of work, and New Jersey's not unique in this, but they do a lot of work to educate beneficiaries that this option exists and work to do that from the plan side, but also from the state side and coordinating with different programs, including their state health insurance program. And I think, a couple other things, which is that there's a fair amount, I think, of, similarity, again, between the MMP platform and the D-SNP model, but one of the things that we, I think, like to point out with programs like this is that, it takes some time, right, to develop the sophistication from the state side, to understand the complexities of Medicare, to oversee models, and figure out, how you basically improve the alignment for a beneficiary. And New Jersey's been operating, I think, integrated D-SNP products since about 2012. They actually started some D-SNP integration efforts before they launched their MLTSS And, today, that's kind of paid off for them. They have about a quarter of the state's dual eligible population enrolled in FICE SNP. They get pretty positive, feedback from beneficiaries and folks that they appreciate, right, this option being available, since they limit the enrollment to full benefit dual eligibles, and which could include swimbies and swimbies, but also includes individuals who are full benefit dual eligible, otherwise eligible for all the benefits under Medicaid, but maybe, at a little bit higher income level than a swimby and a swimby. They work with the plans to make sure that there's zero cost share through SNP, so that from a beneficiary's perspective, there's actually no cost sharing in the model. So they've had a good experience with it, and are a neighbor to New York State, so hopefully it's helpful to know a little bit about their model. So I think the last thing to just point out is there's a couple appendix slides here if you move on through. One, the first two slides are the details of the minimum requirements for the SNP contract. I think the coordination of benefits in New York State, the coordination of benefit agreements in New York State today actually cover the minimum requirements, but don't go I think far beyond them, although there's a potential that some of those CSNPs for different reasons are operating more integrated plans. The actual agreements between the CSNPs and the state, I think, achieve all these minimum requirements but don't go past them currently. So we thought folks might be interested in seeing what those look like. So the next slide is the rest of the minimum requirements, and then the last slide is just some additional resources, some of which I actually think you have in your materials today. So I'm happy to take questions if folks have any. Yes, and I guess if you can go up to the mic and let us know who you are and where you're from, that would be wonderful.
Good question.
Sure.
Are the Medicare components of all of your map operating at site? This may be the wrong, you may be wrong.
No, it's a good question, and the short answer is I think there's a variety of variation in the level of integration that occurs with MAP plans, but I'd love for someone else to answer that better than I can probably.
Some are
Some are DSNP, some are Medicare Advantage plans, like MAC. Yeah, and the requirement in New York with MAP, I think, mirrors New Mexico. It's just like another state where there's a requirement to operate some type of Medicare Advantage plan, and there is then the potential that someone can be enrolled right in the same parent organization, but not all of them are DSNP, or at that level, perhaps, of integration.
one other question. I want to be sure.
Yeah.
I think what you said that any full benefit that is full required
It's almost that, but we'll flip it back and flip it around. The basic requirement is all the full benefit dual eligibles in New Jersey, with minimal exceptions, are required to pick a Medicaid plan. There's authority in New Jersey to enroll that population into mandatory Medicaid managed care, including for MLTSS. So once someone is enrolled on the Medicaid side and making that choice, they have the option. They're not required to enroll in SNP because they can't, require that. They have an option to basically either be in the standalone Medicaid managed care option and the MLTSS plan, or to choose to enroll into SNP on the Medicare side. So they have the freedom to choose the different Medicare Advantage options.
Hi, I'm Emily Baldwin, Medicare Rights Center. Thanks for really helpful and informative. I think one thing that I like to emphasize is the fact that of course, there's but in your enrollment and partial schools, still kind of have
available or data that the state, I know there were some suggestions in the prior conversation about looking, even at like the geographic scope, in different ways, but I would guess Andrew's nodding, but that's something the state could look at. You can also look at the number of DSNPs in a state that are zero cost share or not, and I'm not sure what that landscape looks like in New York State.
Great, I just wanted to say that there's data, and also mention that I've heard of folks who have the Medicare State program and personally enrolled to and just to echo Fred said earlier, I think that when it's a more rural county where there isn't a major hospital network, it's more strict working on network added. There are certain people that have to automatically enroll them because their providers are but we're just network added and stuff. So I have that or both work network.
Very welcome. Hi, welcome.
Hi, I'm Doug Callaghan from here. Looking back at this question earlier, funding extension, I think in either case, to created integration happen in a certain way. Specifically on design, I heard you say some of the fighting is taken as integrate across kernel or FIDA that makes really helpful flow from command perspective of not having that creating process currently process also for beneficiaries because that's not you're not having to road or trying to figure out
That's a helpful comment. Either case, both probably agree. I think we have additional questions. Yeah, welcome.
Hi, Robert Hardy again from the Medicare Rights Center. Dr. Openstock had mentioned that Belfast reported that private preference is integrated into the process. Also, you mentioned resource results very important for us that it's difficult that beneficiaries have navigate the lack of Medicare now a private provider network. Currently, the support available over the plan finder website. Not all that plan have particularly good support and profile. And then there are a number of notices that cross
And you're just to clarify, I think this is we understood, but the number of notice improvements you're saying is under the FIDA model, there's improvements in integration of notices. Great. And it makes me think about one particular thing that I just think is of interest is as states have launched the financial alignment initiative, the FIDA model, there has been this corresponding effort on the part of the Medicare Medicaid Coordination Office, CMS broadly, including the Centers for Medicare, to look incrementally, right, at how you can improve the alignment of materials. So there's new things like an integrated summary of benefits that's available currently for DSNPs, and I can't, predict the future in the crystal ball, but I think there's just this ongoing initiative to take some of the things that you can take from the financial alignment model and the improvements, particularly administratively, that would be a benefit to beneficiaries, and bring those over to the DSNP model. Again, incrementally, sometimes limited by the fact that there isn't the same level of Medicare flexibility or authority under the DSNP model. Some of those things, but it's a really good point.
discussing whether my question was for, in New York, we have in the MAP model, there's some challenges in enrollment between the state primary for enrollment versus for CMS based off of 20 per month for CMS represented funds. And that was some challenges. And the question is, how does New Jersey handle some of those challenges? That's number one question. Number two, on a little different track, this seems to be advocating two separate contracts. Can you discuss regarding the New Jersey model advantage of two separate contracts versus a contract? And
Sure. So the first question, they're good questions and not necessarily the simplest or like easiest answers. I think one, in terms of the enrollment time period, New Jersey and other states make, I think, very specific decisions about how they do the most with the DSNP model to coordinate enrollment. And one of the ways that they think about, and the states have done, is to follow the Medicare contracting cycle and the Medicare calendar, so basically mirror the open enrollment period on the Medicaid side with the Medicare Advantage open enrollment period. Because basically, a dual eligible, they have the option to enroll or disenroll in a DSNP every month because they have a little bit more flexibility in the Medicare Advantage enrollment process. But from a state side, the time when dual eligibles, would make the most moves and think about their choices is during that Medicare open enrollment period. So that kind of addresses from the beneficiary perspective, where there's an alignment effort that states have done, which is usually to follow the federal cycle. The other one is, sorry. Yeah, so duals are all year, but if you actually look at data in terms of dual eligibles moving from Medicare Advantage products, people in Medicare, dual or non-dual, tend to make their choices when they are given information that says you need to make a choice by this time frame, which is during the Medicare Advantage open enrollment period. So there are states that have aligned with that cycle for their Medicaid period. And it doesn't answer your question, I think, about what's more of a systems issue from a state side, which is, and a state policy question, right, is if you have to make a decision by the 20th of the month under Medicaid, but under Medicare you have till the end of the month, that can create, a little bit of confusion. If that's something that happens, say, in the MAP model, it sounds like you're questioning would that make sense to happen or not happen, right, in a DSNP model. New Jersey does coordination with their health plans, and I think that whatever their particular policy or system approaches are from a Medicaid enrollment system, they try to align those dates and give the person the same time frame to make the choice. But I think there's implications from a state side in terms of, right, like why is there a cutoff at the 20th of the month? But that's a really good question. I think the second question, right, which is more around what's better or worse, with two contracts versus a three-way contract. And, I can't answer that question from the plan side, but I would think that it's an interesting question to pose, health plans. I don't know if there's anyone from the plan side who basically, operates under both of those parameters who would have thoughts there. I can say that I often think more about like what's in the contract, and the three-way contract model has a lot that the state and federal partners have sat down and thought about to make it work together in that contract. And I think there's a little bit more effort that has to go into when a state's developing their DSNP contract, right? What's in the Medicare Advantage contract, but more importantly, like what are the additional state requirements that we want to add in? And so really, I think one of the biggest differences I see is having to be very deliberate within the DSNP model in thinking about what the parameters are in the DSNP contract that would achieve, hopefully a level of integration that stakeholders and the states want to get at. So I don't really, see like a clear benefit of either contract. It's more what's in them. Yeah. States that are not operating in the Financial Alignment Initiative cannot do three-way contracts. So that's a good additional clarification. So you can only have a three-way contract with the MMP model. DSNP can't have a three-way contract currently. around the provision of Medicaid benefits, and so they actually unify their MIPA agreement with their Medicaid contract. And so we can definitely go back and look at those and actually share those with you. Be very happy to do that. But I would think that they are pretty standard to what states typically do in Medicaid managed care. I think oftentimes it's a 3-month period. It might be a little bit different. I know within the MMP model in California, as an example, they actually extended, right, some of their continuity of care requirements. So I think that's a state-by-state, decision. The other question about movement, which I think was, what you're asking, right, is how often do people move or how much that has changed. I participate in quarterly meetings, right, with the state of New Jersey, where they often share data on enrollment and, where this program's been. And it's been a steady, right, growth of enrollment in their SNP program. It's at the 26,000 mark currently. And my understanding from them is that there is not a lot of people who, once they're enrolled, who disenroll actively by choice. And this is after, right, their initial period of enrollment, once they've been established in that model. They tend to have, I think they're doing some examination of data in New Jersey right now that I'm not sure that they've disseminated broadly. But so looking at things like past results, my understanding, anecdotally, is that people are pretty pleased that they don't move very often, but I don't know discrete, numbers, what that looks like. Yeah. Yes. There's a couple of things that, I share to the extent that it's helpful from other states, which is, one is that some states have used their MIPA or coordination of benefits agreements to put some parameters around the type of marketing that they'd like DSNPs to do in the state, and who they market to is one thought. The other thing is New Jersey has, I think, a total of 5 DSNPs operating in the state, so the number of Medicare Advantage products in the state might obviously, impact movement as well. So I'll hopefully that's helpful. And I don't see anyone else at the microphone. I haven't looked at a list that is checking on time, but really appreciate all of your questions, and we'll be here if anyone has any follow-up questions.
Thank you, Alex. That was great. We've heard a lot of feedback so far on this, and we're behind our schedule. So I'm going to encourage folks who have additional thoughts on what platform you would like to see the state using for integration to include that in the comments that you submit in writing using the comment template. And as you heard from Andrew, the time has been extended until January, so there's more time to do that, and then we can move along to our next topic and get to Sean.
Thank you. We're just going to talk for the next few minutes about, similar to what Laura was talking about, where you have that churn rate. We're just talking about the consolidation of the existing programs. When we kicked off our meeting here in July, we had a slide that we're talking about the managed care products available in the state of New York for the dually eligible. And I think we're at a tally of about 7 different programs. And today we wanted just to gather some input from the audience. Say, we have these programs that are available for the membership for dually eligible, and does anyone have a sense that there may be a better way to keep some of the members in the plan if they didn't have as many choices? And if that is something, because we think that New York State's a little further than some of the other states in the country on the platform for managed care for dually eligible. You look at some of these things that New Jersey was doing. They did not get into the MMP or apply to type programs, so they were trying to make these other arrangements to get up to a level that the MMP is. We're just wrapping up our 36 months of the program so far. We have another 24, so we did make some changes about 2 years ago to the program, and so we just want to kind of just overall the consolidation of the existing programs, do we want to consider making any changes to that? And when Andrew kicked off the call back in July, we said that we would consider that. We don't know what's going to happen in 2 years. We may have a different landscape of what products are available for this population that we're all serving. But I just wanted to just kind of open it up and see what everyone feels. Do they think that their program, if they sunset something, how that's going to impact the rest of their products that they have? So I want to probably not say we want to get rid of the program in front of everyone else. I understand that, but that's what we're.
A couple thoughts. I think that the Biden demonstration, right? I think that the Biden demonstration, that the benefits of Biden and period about that. The other option, I would say, they think both have and hey, both have proven that it's beneficiary and offer a lot of positive benefits. I think though that there are things inside that we can learn from and to enhance that. And I guess that's my overall preferred approach here from my organization. The consolidated grievance appeal process that Laura talked about, one thing on that is that if legislation and authorized by Congress every year, and the law that is proposed, I don't think it's passed yet, does include conditions for having it. So I think there are ways to enhance that. Some of them may just be CMS regs, some may be REST authorization. I think there's still ways to enhance that, get the way a more integrated plan.
Derek Favors, sounds like math class.
Yeah, but
Yeah, just be clear.
I would say that the coordination allow each to have coordination agreement does not achieve rate, really allows to offer separate Medicare and Medicaid. And, you have a contract for state, but it's not a contract that has been doesn't have benefits, doesn't have finance, doesn't really require anything other than planned care management to focus on Medicare. That's something that I think that it offers through a map plan, that any has to have a state contract that covers benefits.
Yeah, pretty clear.
Today the state has a Medicaid advantage.
Jeff, what was the question again? For Stephen, I'm sorry.
Yeah, Steve, still for non-mobile Medicare eligible, not eligible.
Right. So by what I'm suggesting, I guess I would suggest that that's the point that Medicaid Advantage should offer
And I've seen, we've had comments come in about the integrated program, and even today in the audience. And I remember reading a comment, which I probably did not, or I thought would come in. The plans like, we like the idea of the integrated model, but we don't support when the plan makes the denial automatically go to the next step. So I think that is something that we continue to hear about, the integrated model they like, but maybe not that portion of it. So we'll take a look at that as comment comes as well. Go ahead, Doug.
Thanks, Joe. That's my guess again. So I just wanted to say I really appreciate for your clarifying talking about what I think versus FIDA and where the first line access that is already process right now. So to the extent if there's a sunsetting of FIDA to either MAP or and I think it's helpful if something that comes out that if we kind of get that either improved or launched through that office. I know this is somewhat example, but the office has been very helpful in also supporting CMS. And in fact, kind of the audit protocol for that is adjusted to account for particular cases. So I worry about having to give sort of this Medicare and Medicaid as two separate programs that are integrated somewhat, but that there are other areas that are untouched. And having a constant help those justice that has that.
Any other thoughts on consolidation? We picked up some of the information on, again, comments coming in, some from today. Do we think that we have enough integrated programs here in the state of New York? We have a handful that we mentioned. Do we? Any other way we want to look at that? Now, Laura? I'll put that down for you. Yes, thank you. Okay, thank you. Yeah, Patrick has this lot for the paid program for us at the OH. Okay, looks like 125, so why don't we move on to the last topic that at least Halprin will discuss is on transition.
All right, I'm pinch hitting for Renee, who's unfortunately under the weather and unable to join us today. We're going to talk a little bit about considerations for transition, and obviously as the state develops its plan moving forward and works with CMS and all of you'll know what that is. Once decisions are made, there would be more discussion about transition. But at a high level, we just want to start to at least capture some thoughts you have in terms of what transition process and protections we would want to make sure we incorporate into the move to the future of integrated care. How will we move consumers to the new model? How will we ensure a seamless transition? What kinds of pieces do you feel are most important that you want to make sure gets built into the design of the future of integrated care as it's being built, and make sure that it's a seamless transition, and that we've accounted for everything. So what we're actually going to do is, since people are getting tired and probably hungry, I'm going to write your thoughts on this easel, and Madeline's going to give everyone a Post-it. And as we get toward the end of the conversation, we're going to ask you to come up and put your blank Post-it next to which consideration you think is most critical as we move forward in terms of transition. So if it's continuity of care, if it's continuity of plan, throw them at me. Everyone, get up. You can move a little if you want. We can keep you awake. push getting to the microphone. And my handwriting sucks.
I think our experience from the FIDA past deployment for last 6 years, the feedback that we got from both providers that they had a lack of knowledge. It's better that they didn't quite understand what they meant. So I think it's critical that we educate the providers and prior to. I'm not sure what vehicles to use, but definitely focus groups if you decide the book program.
Got it? Did I get it? Early education? Okay.
Hi, Rebecca Novick from the Legal Aid Society. I'm making kind of a similar point, but really, really want to emphasize how traumatic these kinds of changes to the care that people live and in their homes and people from day to day are for people and have been, and I really want to push, whether it's by the sunsetting or the model being pulled out, whether there's passive enrollment and things like that. Losing what they have. Not that they're not going to use what they have when we're talking about the long-term care population in particular. It's going to be better for every aspect of the system, for the plans, for the providers, for everybody if there is continuity in their care. I think I think the advantage at this point of the fact that the FIDA program just to echo what Rebecca said and to add a bit specific, really to keep the FIDA plan continuity of care rules. Make it more specific, but for, I guess, the 4 states that in general. And we also, I think we're kind of alluding to it, previous folks were kind of alluding to it, but
you use the mic, Megan?
Yeah. And then I would also within places that obviously there's an opt-out process for that, but that is allowed to contact as far as state provider, a long-term provider, and cause minimal disruption on that front. Remember?
Okay, anyone else?
Before, other part that I want to talk about. So the first about what and I think that is different because if you could have an opportunity or whatever and it's based like by guidance because what we did see that the first few calls that a member is going to make is one to their doctor, two their care manager if they had one, and then as well community for friends for them as so it would just be helpful that all of the time after that it's just restricted so that they are not I think they go together. I think they can be clear. I just think that it's important that when we talk about what they are, that the plans have an ability and extension of the department that speaks that all. It's having to transfer the members over to the independent broker weren't really getting some of the questions solved and a lot of opt-outs and other things happen. And so if there is a desire to try to keep people in plans, that's kind of partnering work.
We did do that, right? We had the relationship where, the member would speak to the care manager, and then I would say, all right, Alyssa, transfer you now to Maximus, and then disconnect the call.
Right.
And we saw that really did not help the enrollment program.
So
They did.
we did, but I guess, I just want to, we're talking about what the plan is for transition. I think that's important that still keep that.
We learned it through the pilot program, but take what we learned.
Anyone need another Post-it? Two things you really want to put Post-its on?
Since we're talking about not having more program. Running through transit, but yeah.
me over, trying to get up here. So we want your Post-it. Put your Post-it next to or right on top of the one thing for notice board. Got more Post-its? You'd like to see more than one. Here, Sophie. Put a Post-it on. I'll model a Post-it. Mine. Oh, here. Probably right. No. Maybe that makes me. Yeah, I guess that. No, ripping it in half is better. Instead of, yeah, actually, go ahead. If you can be quiet, we have one other to add. Yeah, so be loud. Okay, I just want to add one more. We're gonna add one more. Discussion. You know, we're talking about a dual eligible population. They have access to both Medicare and Medicaid benefits. We as New York did a fabulous job developing and selling Medicare Advantage plans to the providers, doctors. That's how programs became successful, and that's why, you know, doctors are selling it to their patients. When FIDA program was launched, the Medicare Advantage networks were not used. FIDA plans created a subset of network of providers that are not familiar with the Medicare population in the same way. They're not in the Medicare Advantage plan, which is why most members enroll. So, you know, I'm not sure how to word this, but, you know, one of the things that is learned from this, you know, we're talking about a map, one of the map networks that are already similar in their, you know, of the physicians and providers, just like the Medicare Advantage. So we, you know, we can focus on the physicians and providers network, sell to the right patient. Okay, so that was early education. It's really not, it's or provider buy-in. Yeah. And to identify the right patient. All right. Well, thank you for playing, and I'm going to turn it back over to Erin Case. That was really helpful. That's interesting to look at how many, you know, where all the stickies went and how many people are. It's not how I would have predicted it went. So that was really helpful. So we'll finish up with additional discussion and comments. Based on the time we have left, we were going to ask if there was any additional comments or thoughts that anyone wanted to raise on topics we haven't already covered over the 5 sessions. But since our time is probably getting a little short here, we'll say that if you have ideas for future topics, we
we aren't gonna have any more of these series, but we could, send topics out that we haven't covered in a different way if you think there are any, and if we can't shoehorn it into what we've already covered. You can send those into CML, Future of Integrated Care at health.ny.gov. The follow-up comments, as we said, are requested from you. What we're going to do, as we've done it after some of past meetings, is send out one comment template. I think it's an Excel spreadsheet that allows you to send your comments to us. The purpose of this is not for you to resubmit comments that you've already sent in, but it's for new comments. It helps us to gather them in a more organized fashion so that we can post them and online for everyone to look at, and so that we can review them with CMS forward. Submit those also to our BML, and our target date right now is January 12th. If that becomes unworkable and you think that there's more time is needed, please let us know. Also by email to CML. So for our next step, we are keeping those comments. There's no need to resubmit any of the comments that you've already submitted. We will review with CMS and we'll communicate what the next steps are. We have taken some pretty thorough notes today and in all the other sessions, and we'll be reviewing all of those plus all the written comments and the questions that have been submitted through the webinar and to the BML. And we will decide on the next steps and communicate those in the same way that we've been communicating to all of you with the agenda. Last slide in the deck is just, again, all of the information, which is, of course, the Future of Integrated Care BML, and a link to our website where we post these helpful information. And because I'm Erin Tate and I can never have a slide without BBP on there, and because, of course, BBP will play such an important role in the future of integrated care and all care in New York, here's our BBP BML. We have BBP questions, and there's a link to our website where BBP materials are posted. Remember that in that Medicaid Design District BBP library, we have, if you scroll down, because the library is getting bigger, we have a specific MLCC chapter, which you can open up and find all of those materials there. Any last questions, comments, concerns, Carl? We don't have a specific enough timeline today to really communicate, because I wouldn't want to be wishy-washy and I'll waffle back on it. But we are going to be coming up with that sort of information in a general timeline and sending that out, just materials through, through the same way that we've done it here.
Because, depending on the approach, if this Medicare Advantage kind of plan to go forward with, there is a CMS timeline.
Yep.
And what is your a plan?
Ideas that you want to map out for our consideration, you can also send into that BML. That would be really helpful. You can also send it directly to me, but it's always better to come to the BML, because then it doesn't have a chance of getting lost in my inbox. Not that anything ever gets lost in my inbox. All right, well, thank you all so much for participation in this. We'll be reaching out with next steps. Thank you.
Yeah.